the first thing that I want to say is that I'm hoping that you can all see the slides. And the first thing I want to say as part of this seminar is I am not a doctor. So I am an anal cancer patient, diagnosed in 2010, and no evidence of disease since then. So the comments that I'm making are based more on the patient perception of things. I do have a background in cellular pathology in years past, so I do know quite a lot of what I am talking about. And the slideshow I'm presenting, I did in conjunction with the Colorectal Cancer Association of Canada. So they kindly allowed me to use a lot of their material as well as their logo. They're a phenomenal organization, and there are many brilliant organizations out there internationally that deal with colorectal anal carcinoma. So please reach out to them. So thank you to the Canadian Cancer Survivor Network for inviting me to do this webinar, and we're going to begin. So when I actually managed to switch the slide, which doesn't seem to be happening, let me just get my IT person here. He will come in a minute. Okay. So what we're going to be discussing today, I've lost the webinar thing, but hey ho. So what we're going to be discussing today is who the Colorectal Cancer Association of Canada and who anal cancer bum wrap are. And then I'm going to generally talk about, you know, what you need to understand about what colorectal and anal cancer is. So its symptoms, its risk factors, and colorectal and anal cancer in Canada specifically. I'll touch on internationally, but I'm mainly talking about Canadian-wise. We're going to talk about treatment options, both from a surgery point of view, a chemotherapy and radiation point of view, and biologics. As I reiterated at the beginning, I'm not a doctor, I'm not an oncologist or a colorectal surgeon, so you obviously will rely on the expertise of your medical team if you are a colorectal anal cancer patient. As well as we'll be covering preventing colorectal and anal cancer. Big proviso on that is sometimes there is no prevention, it just happens. So screening, lifestyle options, and then finally we're going to talk about the benefit of peer-to-peer support groups for people with either colon cancer, rectal cancer, anal cancer, and how important I know that is to be, and how I'm involved in peer-to-peer support groups for those things. So the Colorectal Cancer Association of Canada are a national non-for-profit organization, comprised of volunteers, and I can't really read my slides because of that. It's led by a national board of directors, and it's counseled by an expert medical advisory board. It's dedicated to the improvement of lives of patients, and they do an awesome job, and you can find all of these organizations online. So if you aren't tech savvy, then one of your children will be, or one of your grandchildren will be. So please use the power of the internet on safe sites to find out information that you may need to know. And many of us do that, but make sure that the proper sites and well-renowned with good reputations. Okay, so now we're not doing the slideshow again. I apologize for this, everyone. So, I know why. So what the Colorectal Cancer Association of Canada, what they mandate is the promotion of awareness and education for colorectal cancer. Now, when I started, and a lot of my advocates for anal carcinoma around the world, several of us, Claudia, Calvin, Michelle, there's a handful of us who are the powerful advocates, I would say. We wanted to start having anal cancer way more promoted within the colorectal organization so that people with anal cancer could easily get information. So I'm proud to say the Colorectal Cancer Association of Canada also has tabs on anal cancer information, so you can go to those, as do now many international organizations as a result of the work that I and several of my anal cancer advocate supporters have done. So the Colorectal Cancer Association provides support for patients and their caregivers, and they are advocates for primary prevention, screening, and equal and timely access to effective medications to improve patient outcomes. So the massive advances in medication and treatment for colorectal anal cancers is a really important thing, and we try to advocate for that and try to get patients to have that be accessible to those things in a timely manner. So Anal Cancer Bum Wrap, who we are is we're a non-for-profit organisation comprised of volunteers based in Canada and provide international support. We tend to be predominantly English speaking, but saying that, I have had applications and questions from non-English speaking, and so what I do is I reach out to international organisations who are speaking that language, who are dealing with anal cancer and colorectal cancer, and so that they can get support in the language which is their first tongue, which is a very important thing in my opinion. So our mandate is to promote international awareness and education of anal cancer, to provide support for patients and their caregivers, and advocate for primary prevention, screening, and equal and timely access to effective medications to improve patient outcomes. So understanding colorectal and anal cancer, and as I've said, I'm not a doctor or a surgeon or an oncologist, so this is not going to be a hugely in-depth analysis of the many, many different forms of dysplasia and cancers that you can get in the gastrointestinal tract. So for that, you will be speaking to your medical team. So that's what we're going to do. So what we're going to do in this section is what is colorectal and anal cancer, what the stages of colorectal and anal cancer are, what the symptoms of colorectal and anal cancer are, the risk factors, and how colorectal and anal cancer is, what's happening with it in Canada. So what is colorectal and anal cancer is an important thing. So on the diagram you can see on the screen, it tells you what is the colon, the rectum, and what the anus is. So the colorectum, as you can see on the screen, is approximately 6 feet in length, and its function is basically to reabsorb water from digestive contents and serves as a holding chamber for stools until evacuation. So that's what the rectum does. And the anus is the opening at the bottom of the large intestine, and through which stool, poop, poo, whatever you wish to call it, feces, stools, solid waste, exits the body, and it includes the anal canal, 4 centimeters, and the anus. The anus, you can see out on the exterior, the anus. So that is what the differential is between the colon, the rectum, and the anus. So colorectal cancer is cancer that affects the colon or the rectum, and it's also known as cancer of the large intestine or the large bowel. Most colorectal cancers start in cells that line the inside of the colon or the rectum, and typically, I'm not going to say all of them, but I'm going to say typically it grows slowly and is typically curable when diagnosed early. And diagnosed early is one of the key points I'm going to be commenting on all the way through this webinar. Early detection is early prevention, and the prognosis is great for those typically who've been diagnosed early. Advanced colorectal cancer is when the cancer has grown through the entire colon or the rectum wall and into tissues or organs. So these are things that your medical team, if you are a colorectal or anal cancer patient, are going to be talking to you about, and they will give you literature on that. So always ask for it. And if you don't understand what you're reading, please ask them to explain it to you in simpler terms. Everyone should be able to understand it. Ask them to draw you a diagram. Ask them to do anything that helps you understand what it is that's happening to you. There are some people who don't want to know, and they just say, I just want it in the hands of my medical team, and that's fine as well. We understand all aspects of how people deal with their cancer diagnosis and how they want to deal with their treatment process. Some people want to know everything, some people just want to know enough, and some people don't want to know at all. Some people want support, some people don't want support, and that's fine. However it works for you is how it works for you. Just find the way it works for you is the most important thing. What is anal cancer? So anal cancer is the cancer that affects the areas that I've shown. So it's the area that marks the transition between the rectum and the anal canal. It can affect the anal canal, and it can affect the anus. There are a variety of anal cancers, and the prognosis of most of them is better if caught early. So the thing about the anus and the anal canal and that zone between the rectum and the anus is it's called the transition zone, and there's a variety of different kinds of body cells that like living in that transition zone. So that's why you can get a variety of cancers all in that zone. Some are typically squamous anal, some can be adenocarcinoma anal from the anal glands or down from the rectum. You can get melanoma, lymphoma, sarcoma, neuroendocrine. There's a whole variety. In the same way as if someone has colon cancer or rectal cancer, it's not necessarily always adenocarcinoma. There's other things. But as I say, I'm not a doctor, so I'm not going to go in depth as to the different kinds of cancers. That's for something that your medical team, who you really must trust, is going to explain things to you about that. Stages of colorectal cancer differ in anal cancer. So when people talk about staging in anal cancer, it's not the same as when someone's talking to you about their colorectal cancer. So staging describes the extent of the cancer, and it's based on how many layers of the bowel wall are affected, if lymph nodes are involved, and if it's spread to other organs. That's the same for both colorectal and anal cancers, but this is when it starts to differentiate. So stage 1, 2, 3, 4, colorectal is slightly different in how it's staged from anal, and you'll see that in the next slide. There are other staging mechanisms for cancer. There's several brilliant ones, and the doctors will explain to you what those are. So people talk about stage, type, size, any lymph node involvement, metastasis, and the same is to be said for anal cancer as well. But we're going to keep it easy, and we're just going to do with what most people will consider how they explain to people what kind of cancer it is that they have and what stage that they are at. Stages of anal cancer differ in so much as stage 0 is abnormal cells found in the innermost lining of the anus, and they may become cancer cells and spread into nearby normal tissues. And an anal pap, which stands for Papa Nicolau test, which is the same as a cervical pap, would detect these abnormal cells, because typically it's a squamous cell. And don't be overawed if you're not understanding the names of the cells. It doesn't matter, because your doctors and nurses are going to explain this to you as well. So cells can be abnormal and may be turning cancerous, and that's why people have cervical paps done to check for cervical dysplasia. The same can be done for anal dysplasia, so we can catch it at that stage. I'll talk about screening later on. Stage 1 is when the cells have truly turned over into their malignant phase, so they are cancer cells. And if you're stage 1, then you have cancer, but it's less than 2 centimeters in size. If you've got stage 2, then it's over 2 centimeters in size. And then it differentiates into stage 3A and 3B, which the tumor can be any size, but it's spread to lymph nodes. So in anal cancer, they make a differential between which lymph nodes they are. So it's near the rectum or into nearby organs, such as the vagina, urethra, and bladder, for organ involvement as well as lymph node involvement. And stage 3B is the tumor can be any size, and it's spread, one, into nearby organs and to lymph nodes near the rectum, or to lymph nodes on one side of the pelvis and or the groin, or may have spread to nearby organs, or to lymph nodes near the rectum or the groin. It's complicated, I know, but don't lose me on this. It's just the way it is, but don't be overawed by it. And lymph nodes to either side of the pelvis or the groin, and they may have spread into nearby organs. Stage 4 is the tumor can be any size, the cancer may have spread to lymph nodes anywhere, nearby organs, or to distant organs. So in the same way that colorectal cancer can metastasize into the liver, the lungs, the peritoneum, you name it, there's many things. Anal cancer can do as well. So you can get lung metastases, bone metastases, liver metastases, a whole slew. So again, your medical teams will explain that to you if you want to hear it. And if you don't, then that's fine. Just carry on with the treatment and just all is good. So the symptoms of colorectal and anal cancer is a huge overlap in colorectal and anal cancer, which is why we really strive for anal cancer to be included in colorectal organizations, because the symptoms are so very similar. We're all part of the lower intestinal tract, and we are a vitally important part of the colon rectum. So The symptoms may not be present in early stages. That's the most important thing to know. So people, sometimes when you hear one of your friends or colleagues say, I've been diagnosed with stage 2 or stage 3, sometimes you might think to yourself, wow, how could you not have known? But sometimes it's just the way. It's just you may not know. So if or when symptoms appear, they will vary depending on the cancer's size and location. And I have to say that the most common misdiagnosis for anal cancer and a lot of rectal cancers, I have to say, is the patient and or the primary care physician thinking that the cancer is just hemorrhoids. And we hear that time and time and time again. And so please, if you think you have hemorrhoids, please see your doctor to begin with. And if you've got hemorrhoids and you've been merrily going to the pharmacy and buying things over the counter and your hemorrhoids haven't gone, please see your doctor, because there may be a reason they haven't gone, because your hemorrhoids, they aren't hemorrhoids. So the symptoms that you can look for are many and varied. So we'll start at the top with constipation. Not everyone with constipation has cancer, but constipation is one of the most common symptoms of cancer, because what it can demonstrate is that there is a blockage forming for whatever reason somewhere within the intestines. So constipation, abdominal cramping, which you've not had before, bloody stools. Of course, we have tried to preach over the 30 years that I've been involved in the medical field, on and off. If you've got blood when you go to the washroom, please, please go and see your doctor. Please try. I know it's embarrassing. I know it is. But it's not worth dying for. Your family physician is there to help you. They have spent years training to save people's lives. They see people's bottoms day in and day out. They're not embarrassed. They want to save you. So please try to get over embarrassment for going to the doctor for these symptoms. Bloody stools, it can be bright red blood, or you can look at your poop and you think, oh, it's looking very dark, because the further higher up the colon rectum that the blood's coming from, by the time that that poop has managed to make its way out, the blood has broken down, so it's a darker color. So it looks black, a blacky, muddy brown and tarry. So please, we can't reiterate enough. Unexplained weight loss. There's many reasons for unexplained weight loss, but cancer is a pretty typical one for that one. Loss of appetite. You know, it's not normal to not feel hungry. So please see your doctor. Nausea and vomiting. Nausea and vomiting can sometimes occur as a result of the fact that you've got a blockage in your intestinal tract somewhere, and your food, once it's gone through the stomach, actually can't make its way down and be pooped out because there's a blockage. So what your body will do is try its best to get rid of it, and what it'll do, you'll start vomiting. And some people do vomit and it can smell a bit like poop, because that's what happens. And again, please go see your doctor. Unexplained gas and bloating is a big sign of a variety of cancers, including colorectal and anal. So if it's unexplained gas and bloating, please see the doctor. I know it's embarrassing because nobody wants to go to the doctor to talk about gas, farting, pooping, however you want to say it. But please, please, they're not embarrassed when you go to them. It's you that's embarrassed. And you'd be so, your family would be mortified if you died simply because you were too embarrassed to go to the doctor. That is the biggest thing we say. Please do not. Unexplained fatigue. Cancer is renowned for creating fatigue. In anal cancers and rectal cancers, you may be itching. So that means that in your anal area, so in your bum, you may feel this itching, and sometimes it feels as though, some people describe it as they feel as though little worms are crawling all over the anus and in the rectum inside, and other people explain it as just this weird internal itch that you can't do anything about. And so that is a sign. And if you feel a lump, now feeling a lump is the same as the hemorrhoid crew. So I'm going to say if you've got hemorrhoids, then most of you realize you've got hemorrhoids because A, you can see them, Some of you never look at your bottoms in a mirror, and I understand that. But you know what? Maybe you all should start having a look, and then you'll be able to see what your normal is. And if you can feel a lump on the outside of the anus or just on the inside of the anus, then please go to see your doctor, and your doctor will give you what is called a digital anal rectal exam. It's called a DARE, that's its acronym. And what they'll do is they very, very gently, with a lot of lubrication, put the finger inside your anus, and they'll do a sweep, a 360-degree sweep. And the finger goes up quite a way, which also means it can feel lower rectal cancers. And seems though the numbers of lower rectal cancer in the under 40-year-olds is statistically on a massive climb. I personally believe, as do all my advocates, that every single family physician, gynecologist, should be doing digital anal rectal exams on all of their patients, because it is one of the most easiest, simplest examinations to do and could help save many, many people's lives. So we're great advocates for the digital anal rectal exam. Risk factors for colorectal cancer are many and varied, and sometimes, as I said, there's none. Age. The older you are, typically the risk was higher. That is still true, though, as I said in the previous slide, the number of under 40-year-olds getting colorectal and/or anal cancer is on the rise massively. The Mayo Clinic put out a report last year pleading for all primary care physicians to please send their young patients for further diagnostic screening if they're presenting with symptoms of bleeding, cramping, bloating, blockage sensations, because we're just seeing a massive increase in the number of rectal carcinomas. And so age doesn't matter. If you've got symptoms, please see your doctor. A patient's history of polyps, cancer, or inflammatory bowel disease is also really important. Now, if you've got polyps and that's been found on a colonoscopy, or you have a family history of polyps, there are genetic symptoms, familial adenomatous polypi, to name one, but of several. So be aware of what your family history is. We can't reiterate this again. As you can tell, there's a lot of things we can't talk about enough. Know your family history. Know who's died in the family and of what did they die from. Because knowing that means you may have an idea as to the genetics of your family tree. And knowing your genetic family tree and the illnesses and diseases that come with that is vitally important. A family history of colorectal cancer. If someone in your family has died of colorectal cancer, especially if they're an immediate relative, mother, father, sibling, child, etc., then that basically should be giving everyone a red flag. And everyone who's an immediate sibling should be getting checked 10 years prior to when their family member was diagnosed with colorectal cancer. I'm not going to speak so much on the anal cancers because it's not got so much of a genetic link as yet, hereditary-wise, but the colorectal cancers, they most definitely do. So 10 years. So if you got an uncle who was diagnosed at the age of 60 of colorectal cancer, you should be getting screened, diagnostically screened at the age of 50. That's the age of routine screening anyway in many, many places. But if you have someone who died at the age of 50 or 45, then you're getting screened at 40 or 35 or younger. And I know this causes an issue with, especially in the States, with insurance issues, with the insurance company. Will they pay? Will they not? But it needs to be done. So just do it, and if you have any symptoms whatsoever, I don't care how old you are, whether your child is 3 years old and pooping with blood in it, or you're 80 years old and you're pooping with blood, I want you to go to see a doctor, please. Genetic syndromes I touched on basically before. There's many of them, and I know that as the advancements in genetic research go, we're going to find more genetic links to a whole array of cancers. But genetic syndromes for colorectal cancers, FAP, Lynch syndrome, it's called something else in Canada, it's non-hereditary, non-polyposis, something or other. Anyway, you'll find it. Racial ethnic background does play a part in colorectal cancer incidence, so just be aware of that. And lifestyle-related risk factors. There are some risk factors, but you know what? Some people get colorectal anal cancers without having any of the risk factors at all. So being aware of your own body is the most important thing. I don't care if you're a vegan and you're running 10 marathons a year. That does not exempt you from the potential of having colorectal or anal cancer. So even though you may think you're the most healthiest person in the entire universe, you may still get it. So please go to see your doctor if you do. Risk factors of anal cancer differ slightly from those of colorectal cancer. And there's several risk factors which may increase the developing of the most common type of anal cancer, which is squamous cell carcinoma. Those include age, the frequent anal redness, swelling and soreness, inflammatory bowel diseases. So if you've had a chronic anal rectal disease for decades, so if you're a Crohn's disease, you've suffered from anal fissures a lot, you've got internal or external hemorrhoids, even though there's no tie between hemorrhoids and cancer, it's still a chronic inflammation. And so, if those cells are constantly bombarded with irritation all the time, it's not surprising that sometimes the cells just give up the ghost and start doing strange things, which may mean that they turn dysplastic, which was a bit abnormal, or turn into cancer. Having anal fistulas, which is different from an anal fissure. So an anal fistula is where you get a sort of little canal, if you will, that leads from the anus and comes out somewhere weird. It might come out into your vagina, or it might come out on your buttock cheek. There's those things. That's a risk factor. Lowered immunity. So people who are living with HIV, or people who are on any form of anti-rejection medication, so organ transplants, immunosuppressive drugs, for anything. The reason that lowered immunity may be playing a part in that is because 85%-ish of squamous cell carcinomas of the anus, as well as head and neck cancers, so the oropharyngeal, and we will find many more, let me tell you, are related to having an infection with the human papilloma virus. Most people, 80% of the sexually active population across the globe, will have an infection with one or several of the 170 known types of human papillomavirus. And no one is immune unless you're celibate, and even that, maybe not always so. And if you're immune suppressed, your body may have a bit of a problem getting rid of this human papillomavirus. Most people naturally get rid of human papillomavirus within 2 to 3 years of an infection of it. And as I've said, 80% of you who are sexually active, the odds are you have it. Unless both you and your partner were both virgins when you met each other and you've been monogamous ever since then, but even then there's a risk factor, so please be aware of that. Having multiple sexual partners is a risk factor, but this is one of those things that I talk about when I give these talks to my male homosexual groups or my female heterosexual groups. What's the difference between, you can have sex with 10 different people a week and one of those people may have human papillomavirus or some other sexually transmittable disease infection, or you can have sex 10 times a week with the same person who has the human papillomavirus or another sexually transmitted thing. So it's not a case of multiple just increases your risk of meeting someone who has the infection already. So promiscuity is certainly not the reason for many cancers, so don't worry about that. Having receptive anal intercourse is a risk factor. It is not a prerequisite for anal cancers at all. Studies have proven this, and this has been one of the biggest things that we have tried and keep trying to get rid of, this stigma that everyone with anal cancer has been having anal sex. That is not the case, and truth be told, even if you have or are having anal sex, doesn't mean that you can, take the blame on yourself. That's just not fair. Don't beat yourself up. This is just not, If everyone who had anal sex talked about having anal sex, or if everyone who had anal sex got cancer, we'd have a world pandemic. Let me tell you, anal sex is one of the biggest taboo conversations in the world, and we know from studies that have been done internationally and anonymously by various organizations that anal sex is very common and has been very common for years past, millennia past. Some people don't have any risk factors at all, which I keep saying, and will still develop anal cancer, and the squamous anal cancer is significantly on the rise, not only in the male homosexual and or male homosexual HIV positive and or the HIV positive community, but also in the female heterosexual HIV negative community. We have our contemplations as to why that's happening, but just be aware that it's on the rise in female heterosexual. So no HIV, no anal sex required. It's just on the rise. Other types of anal cancers include the adenocarcinomas, the melanomas, lymphomas, sarcomas, and neuroendocrine. The one thing about the anus, the anal canal, and the anal rectal junction is it's the most fascinating little piece of your body, which takes up, you know, maybe 5 or 6 centimeters, and so much goes on and can go on in there that it's just a fascinating organ. And so if I ever was to become a doctor, then I truly would be a colorectal anal cancer anal surgeon and specialize in looking at an organ which I find absolutely fascinating. And it's so important because at the end of the day, that's what allows you to go out in the day without pooping your pants all the time. So colorectal cancer in Canada, what's been going on with this? Now, this was a slide that we used statistics in 2014. We can look at what's been going on in 2015, although stats tend to come out around about now. So approximately 24,000 Canadians will be diagnosed with colorectal cancer this year. 24,000 that was in 2014. It'll be more. 24,000. It's crazy. It affects men and women almost equally. In Ontario, there were nearly 9,000 cases in 2014. And screening rates are low, despite provincial screening programs. And I think that the biggest issue we have with colorectal, especially screening programs, is this embarrassment factor that people have got. They don't want to go to the doctor to talk about poop. They don't want to go to the doctor to talk about the fact they're bleeding from the bum. And, you know, if you guys or any of your patients or any of your friends or family started, for some unknown reason, bleeding profusely from their mouth, you'd be at your dentist yesterday or your family physician yesterday saying, look in my mouth, what on earth's going on? Why am I bleeding? Why am I sore? What are these lumps? What is this? But because it's down there, and it's all related to sexuality and everything else, a lot of us get so embarrassed about it, and a lot of people are dying because of that. And we really have to try our best to both empathize with that embarrassment, sympathize with that embarrassment, but also try to increase the pickup rate for provincial screening programs. So, you know, in Canada, it's when you reach the age of 50, ideally, you start screening. So that's a colonoscopy or at least a stool test, so to test for blood. So it's the fecal occult blood or the fecal immunohistochemistry test, the FOB or the FITs, FOB or FIT, sorry. The FIT is more precise, and that will probably be taking, you know, over the FOB testing. But whatever you do, whether you're a doctor, a nurse, an advocate, a patient, please talk to your friends and your family. If you start to talk about it and we take away the stigma of talking about this, it will help all of us, and it will help save so many thousands and thousands of lives. It would be amazing. And the treatment for these cancers is horrendous. It's not easy. So it would save people having to go through all that as well. So please, 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 whatever you can do. Anal cancer in Canada. So anal cancer is classified as a rare disease globally. And a rare disease is, a cancer gets the designation of a rare disease if it doesn't affect over a certain amount of numbers a year. So we are classified as a rare disease, very rarely spoken about because of the massive stigma of talking about the anus. So once upon a time, no one said they have colon cancer. And then it became more common to say, for people to say they have colon cancer. And then the ones who had rectal cancer started to put hands up and say, you know what, I have rectal cancer and I'd like to say I have rectal cancer. And at first everyone was mortified that people caught mentioning the word rectum because it was just the big no-no. Same as stating breast 50 years ago. No one said it. Cervix, vagina, penis, testis, all of these words which have been the big taboos. Times are changing, so now colorectal is a very, very common terminology, but even the rectal cancer patients feel embarrassed and stigmatized by it. And if the rectal cancer patients feel stigmatized, let me just give you an idea as to how stigmatized an anal cancer patient feels. Think about it. If the rectal crew can't talk about it, the anal crew are equally and more so embarrassed, and we need to eradicate the stigma. And we eradicate the stigma by speaking about colorectal anal cancers in one breath. All colorectal organizations have anal cancer information on them, so an anal cancer patient does not have to try their damnedest to find information that's buried somewhere on the internet about anal cancer. It should be out there so that stigma is lost. In Canada in 2015, there was approximately 1,000 cases of anal cancer. Most of them would have been squamous, but there were melanoma, lymphoma, sarcoma, the ones I've mentioned. They are the highest amongst men having sex with men. Men, acronym for that is MSM, and who are HIV positive, especially the squamous, because 80–90% of the squamous is associated with human papillomavirus. And if you're immune suppressed for any reason, then you're going to have difficulty fighting off a virus which 80% of the sexually active globe have. So it's not surprising, really, that it's increasing. However, as I've said before, squamous cell carcinoma of the anus is steadily increasing in the heterosexual HIV-negative population, and especially in women over the age of 40. And so, you know, family care physicians out there and gynecologists out there, please do the digital anal rectal exam. Have a look. See what's going on. If they're coming to you for their annual physical and they're doing the cervical pap, you've already got the legs up in stirrups. Really? If you explain to your female patients and your male ones what it is you're doing and why, then they'll understand. Obviously, there's always going to be those ones that are embarrassed. But you try your best. Just try your best. That's the most important thing. One of the philosophies that we have as to why we're seeing this increase in women over the age of 40 with squamous cell carcinoma, typically with human papillomavirus, but most not, without anal intercourse, or some of them have tried, but they're not frequent anal intercourse people, is what I say when I go to my conferences. I'm a member of the International Anal Neoplasia Society, and I do give talks in different medical conferences in North America. The most common sexual position for a long-term married couple is that the woman's on her back and they make love to each other and the husband ejaculates, and as we all know, the semen enters into the vagina, but some of it comes out of the vagina and it goes down. It goes over the perineum and it will go around the anus and it goes onto the bed sheets. And if one or either partners, usually if you've been in a monogamous relationship for years, you're just merrily giving the HPV back and forth between each other, then if the human papillomavirus is merrily shedding at that time, maybe it's carried in the seminal fluid. So that human papillomavirus has just got itself a free ride onto your wife's anal region. So that is why, that's one of my philosophies as to why it's going up. And I have to say, when I talk about human papillomavirus, and we're talking about genital warts specifically, that's what everyone will think about. Human papillomavirus, there's 170 types of them. The benign forms of human papillomavirus, those are viruses which aren't known to cause cancer, they're the ones that cause the warts. So hand warts, skin warts, feet warts, genital warts. So just because you've got human papillomavirus does not mean that you've also got warts. You can have human papillomavirus and have no idea that you have it. And most people with anal cancer don't necessarily have warts. Okay, so on to the next slide. What we're going to talk about is treatment options. Now, I have to say that treatment options in anal cancer, and that's what I'm talking about here, not colorectal, rectal and anal overlap a bit, but this is for anal, is every single anal cancer patient will have treatment individualized to them. So you will rely on your medical team, you'll rely on your surgeon, if you have one, your radiation oncologist, and or your medical oncologist, your nurses, social workers, dietitians, you name it, rely on them. Ask them. If you don't feel comfortable with them, tell them why you don't feel comfortable with them. Don't be embarrassed. This is your life they are dealing with. You have the right to talk to them and tell them what's worrying you. So surgery, chemotherapy, radiation, and biologics. Always talk to your doctor about the pros and cons of each. And you know what? Some people decide not to have any treatment at all. And everyone is entitled to their own opinion as to how they deal with their disease. Surgery remains the primary treatment for colorectal cancers and can be an option for anal cancers. In the very early stages, colorectal especially, surgery can involve removal of a polyp during a colonoscopy, or in the case of anal cancer, a small lesion can be removed surgically if it's known that it won't impair sphincter function. So the anus has got two sphincters, internal and external, and that's what keeps closed so your poop doesn't fall out whilst you're merrily walking around. In advanced surgeries, such as a colectomy, a section of the colon and or the rectum can be removed, and in the case of anal cancer, advanced surgery includes the removal of the lower part of the rectum and the anus. If possible, the remaining parts of the colon and rectum are reconnected to the lower rectum or anus if you've got it left to create a functioning colon, or you'd have to have a stoma. The removal of the anal cancer in the anus results in a permanent stoma. I'm not going to talk in depth about what stomas are. That is a subject to have with your medical team if indeed you're going to have a stoma. But as one of my friends here in Ottawa says, better with a bag than in one. Lots of people get embarrassed about the thought of having a stoma, but I'd rather have a bag that I put my poop in off my stomach than be dead. So please be aware of that. Chemotherapy and radiation. Chemotherapy, as you can read on the slide what it is that chemotherapy does. So it stops the growth of cancer cells by destroying them or stopping them from dividing, and it can also be used to reduce the size of metastases. Chemotherapy works on all cells that are very quickly dividing, not necessarily just cancer cells, but that's the main aim of the game. Drugs are administered via the bloodstream, usually through a vein or orally. Then you've got your radiation therapies. It damages the genetic material within cancer cells and it limits their ability to divide. Normal cells are also affected, but they're able to repair themselves in a way that cancer cells are not. And then we have biologics, which is the up-and-coming treatment forms. So they target parts of cancer cells, which makes them, what is it that makes the cancer cell different from a normal cell? That's what biologics tries to get without harming normal cells. They're a man-made version of an immune system protein. Fits like a lock and key with a particular protein, and they lock on to those cells or proteins and stop their activity. The advancements in biologics, personalized medicine, immunotherapies, biotherapies is massive. This is another webinar on that because you could talk for an entire year on what's been going on that. So the personalized medicines identify genetic differences in individuals that affect the way people respond to drugs, biomarkers, biological molecules, and the cutting-edge cancer research that's going on now for many cancers, including anal cancer, is being carried out worldwide. There's a lot being carried out in Ottawa. So if you go onto the BioCanRx website, that's the Ottawa Hospital, and scientists are doing amazing work on biotherapeutics, including anal cancer. So it's exciting times, very, very exciting times, and we're hoping that things are done in time so that we can start saving more people. Anal cancer treatment has its side effects, typically as a result of the pelvic radiation. It's called pelvic radiation disease. Radiation therapy is highly effective in the treatment of anal cancers, typically squamous and adeno, and there have been huge improvements in radiotherapy techniques and equipment over the years. So don't be scared about what your great uncle died of when he had radiation back in 1960 or 1970, and you hear about them, all their organs were fried and it was horrendous and all this stuff. Times are a-changing. But because of the nature of the treatment, the radiotherapy can affect tissue and other organs in the pelvic region. And those effects of radiation we call is the gift that gives on giving. And it can last for years and years and years. But you know what? Better to smile and live with consequences than be under the ground somewhere. Issues can include sexual function issues, including vaginal stenosis and erectile dysfunction, anal stenosis, bladder issues, joint pain, especially lower back, hips, and upper thighs, rectal and anal bleeding, and the loss of fertility in women as a result of the radiation. It's very difficult not to affect the ovaries when you're doing pelvic radiation disease. All of these things should be taught to you. If you're a patient, then your medical team should be talking to you about this. Everyone should know about pelvic radiation disease. There are phenomenal websites about that. Everyone should know about sexual dysfunction. Everyone should be talked about vaginal physiotherapy as a result of pelvic radiation. Everyone who has anal cancer or rectal cancer should also be under the care of a gynecologist, in my humble opinion, or a primary care physician who's brilliant at also dealing with sexuality issues and the physiology of the vagina. Preventing colorectal and anal cancers, we're going to talk briefly about screening, healthy lifestyle, the human papillomavirus vaccinations, and then the benefits of peer-to-peer. And I'm talking quicker and quicker, and I'm hoping you can understand me because I know my accent is strong, because I know Mona wants to chat for a couple of minutes. So for colorectal cancer screening, the average risk person, so this is average everybody, doesn't have a family member who's died of colorectal cancer, who is not bleeding from their bottom or isn't feeling a lump. I'm not talking about people with symptoms. I'm talking about people who don't have any symptoms whatsoever. So the Colorectal Cancer Association of Canada recommends that the average risk person start screening for colorectal cancer at the age of 50 through the use of what we've talked about before, either the FOB or the FIT, at least once every 2 years. If you can get a colonoscopy, great. Anal cancer, colonoscopy. By the time the colonoscopy is up into your anal corridor and they only start looking, they've missed the anal corridor altogether. Anoscopy, they need to be looking at the anus and the anal corridor as well. Pregnant pause about there, I'm repeating it again. Whoever's doing your colonoscopy, please look at the outside of the anus and the anal canal as well, because you will miss anal cancer. High-risk persons, we've already talked about family history of colorectal cancer, or someone who is symptomatic. And you should start having a colonoscopy as soon as you have a symptom, regardless of how old you are, symptomatic, or 10 years before the age of onset of when one of your relatives got it. By the time your relative was diagnosed with stage 1, 2, 3, or 4 rectal or colon cancer or anal cancer, that cancer had merrily been growing slowly for a couple of years before then. It doesn't just suddenly wake up one day with stage 3. So bear that in mind as well. So that's why they do 10 years beforehand, so we can hopefully catch you all before it starts. Anal cancer screening, there's no national guidelines for general population. And at present, it's mainly carried out for high-risk population, which is our organ transplant recipients, our HIV-positive population, our men having sex with men, or past anal cancer patients. And the screening includes any of the following: digital anal rectal exam, high-resolution anoscopy, colonoscopy, anal pap, smear testing, human papillomavirus swabbing, and precancerous anal neoplasia can be treated at this stage. Anal neoplasia is similar to cervical neoplasia in the same way that the cervical screening program has saved thousands upon thousands of lives over the 20-odd years that it's been in existence. Anal screening would do the same. Obviously, we cannot do it on the general population because it is financially not viable. So we do it on high risk or people with symptoms. Preventing colorectal anal cancers. As I've said before, be aware that sometimes there's no apparent reason for why people get colorectal anal cancer. So don't beat yourselves up. And you know what? Even if you've eaten red meat or you've not exercised 5 times a week, please don't waste your energy beating yourself up about a cancer diagnosis. Just deal with your treatment and live for the day, and just keep your eye on the prize. I get so many people who send me emails because they feel so guilty. I feel guilty for having done this. I feel guilty for not having done that. And I think, crikey, do you think every child's parent who they bring into CHIO has broken their leg climbing a tree felt guilty because they climbed the tree? No. Let's not blame what could or could not have been a cause. Let's just deal with it. We're going to deal with it. We're going to try and help you make you better, and that would be good. 5 minutes. So moderate exercise, healthy weight, good diets, limit alcohol, no smoking, etc., etc., and talk to your doctor about human papillomavirus vaccinations. Please, please. Anyone up to the age of 26, male or female, and we would adore it if all the children under the age of 9 or before sexual activity could do it. Finally, we've only got a few minutes, but the benefits of peer-to-peer support. I cannot thank all my patient advocates enough who administrate, support, help, advise numerous cancer patients, regardless of what cancer it is. You are vital and important. In addition to the advice and support of your medical team, the availability of support for cancer patients who've had the same cancer as you is so important, especially for rare and highly stigmatized cancers such as anal cancer, because I'll tell you, when you're diagnosed with your anal cancer, you just think, oh my God, who can I tell that I've got anal cancer? No one's going to want to listen to the word anus. Oh my God, come to us. We're here. We're online. We can support you on phone, on email, on online forums. Colorectal cancer, anal cancer, breast cancer, penile cancer, testicular cancer, vulval cancer, cervical cancer, whatever you've got, embarrassed though you may be, we're here to help you get through it. We are here. So many international support organizations that provide all the things, emotional support, advice for dealing with treatments, information on clinical trials, and there are specific anal cancer support organizations as well as colorectal anal cancer supports, and you can contact me for more information. But I'm going to, you know, there's so many, Colon Cancer Alliance, Colon Town, Anal Cancer Bum Rat, which is my own, Anal Cancer Chat, you name it, there are out there, and we are here at the end of a phone, a Facebook, a Twitter to help you. Testimonials, this is just to reiterate what I've already said. You can read what the slide says. I don't know what I would have done without the advice and support I got here. So few people have had this cancer, so where do I find advice from? So they go online and they find us. We can give advice that sometimes your oncology staff can't give you. Please remember that your radiation oncologist, your medical oncologist, they're there to save your life. Sometimes they're so focused on what they're doing to save your life, they don't always have the time to talk about your sexual dysfunctions or after effects. It's not that they don't care, it's just that they don't have the time, and that's okay. They've got so many patients. Just be aware of that, please, and know that there's others around us here that do that. Anal melanoma, you know, it's so rare. You don't understand the wordings, and we're here to help you. Why was it important to one person? Because we know what you're dealing with when other people don't. You can hear of different treatments from different people. It's interesting to know what the people are doing. It's important because when we give bad news, people are understanding and sympathetic, and, you know, we make people not feel alone. You're not different from other people. You may have a cancer that's in a rare place, but you're not different. You're just you, and we're here to help you about that. We don't get embarrassed. And I have got 2 minutes to go. Please talk to your doctor about it. And we laugh and we make humor is a very important part of getting through cancer treatment, and if anyone knows all the anal butt jokes, rest assured we do. March is Colorectal Cancer Awareness Month, 21st of March is Anal Cancer Awareness Day. As we always say, talk about it, break the silence, lose the stigma, and save more lives. And I'd like to thank you so very much, and I'm going to pass you back to Mona now for the questions.
Thank you so much. I think that the whole cancer community is very much enriched in Canada by Helen's commitment, and how informed she is and her passion about that cause. It's very, very evident. Now, if I can get some tech help, I can't lose this screen. Okay, I'm good now. Thank you, tech help. I'd like to thank Helen Hutchins for joining us today and offering her expertise to us on this subject. This webinar will be available online from tomorrow. There will be a full video on YouTube as well as slides, which will be on our slide share at CCSN. Links to both will be sent out tomorrow afternoon. We hope you all have a wonderful afternoon for the rest of the day today. And don't forget to join us on, well, except for people in California, I think you're still in the morning. Don't forget to join us, our Ottawa friends and colleagues, on February 4th from 3 to 5 at our office in Ottawa for World Cancer Day Open House. If you want more details on us, please write to us at you can write to me at mforrest@survivornet.ca. You can call us at 613-898-1871 and get the details for our World Cancer Day Open House, 3 to 5 p.m. on February 4th. Thank you all.
So do you have any questions?
Do we have questions, text board?
I can drag that up.
Okay, I guess we don't have questions right now. Not that I'm seeing. I think that we all need to absorb some of this and, pardon?
No questions.
No questions, okay. I think that this information is probably a lot to absorb and people need to think about this. But I assure you, if you want to write us on www.survivornet.ca. If you have a question afterwards, I assure you that Helen will be pleased to answer it at a later time. Thank you all for joining us today for this very informative webinar. Thank you, Helen, for being with us. And goodbye, everyone.